Good afternoon, ladies and gentlemen. I just want to welcome you to this session 8 of the virtual education series for transplantation patients. The subject today is going to be focused on the pancreas transplantation and what are the options that the patients have. These sessions are organized by the joint effort of Columbia Renal Pancreas Transplantation Service and the Lifebulb Corporation, and are sponsored by Veloxis Pharmaceuticals. First, I would like to introduce to you our moderators and also the distinguished panel of experts that we have. So I'm Mark Hardy. I'm a professor of surgery and a director emeritus and founder of the Columbia Transplant Effort. Dr. Hehenberger is the CEO of Lifebulb. She also is an endocrinologist and a PhD in endocrine science. But she is also the CEO of Lifebulb, I may have mentioned that, but more importantly, she's also the recipient of a kidney and a pancreas now for more than 10 years, and she is a true expert. I think our third moderator is missing for the moment, so let's start with the panel. I'll go alphabetically. So Dr. Dube, who is all the way over to your right on the screen, is assistant professor of medicine. He's one of our distinguished transplant nephrologists, and he is the medical director of the pancreas transplant program. Dr. Casey McCune is also an assistant professor of surgery, and she's the surgical director of the pancreas transplant program. And Dr. Sandoval, which is on the lower end on your left, is assistant professor of surgery and major kidney transplant and pancreas transplant surgeon at our institution, as well as the director of the chronic kidney program. So these are very distinguished and experienced panelists. And let's start with the first question. Oh, I'm sorry. Dr. Hagenberger, could you like to make some
I think
comments?
you said everything very well. So I just want to welcome everyone and the audience. And as always, feel free to ask questions. We have some questions that have been submitted already. And of course, we want to take this opportunity to really serve your needs. So as you have questions, please submit them. I will keep the queue. This is your opportunity to ask questions around pancreas transplant. This is, not a very common procedure, but it's a potentially life-changing procedure, as I'm well aware of. So welcome everyone, and again, thank you to Veloxis and for enabling this.
And feel free to ask the questions. So why don't we just start with the first question, the obvious one, and we'll go around among the panelists. Let's start with Dr. Dube. Is under what circumstances, if I have diabetes type 1, when should I decide to get a pancreas?
So, in order to be eligible to get a pancreas transplant, you just need to have diabetes and you need to be on insulin, right? And we kind of started using pancreas transplants even for patients, selected patients with type 2, what we think of as type 2 or adult onset diabetes. So for most of our patients, both here at Columbia and nationwide, they start thinking about pancreas transplant in the setting of more advanced kidney disease. So as their kidneys start to fail, and we start talking to them about the possibility of kidney transplantation, for selected patients with diabetes on insulin, we can also discuss the possibility of a pancreas transplant. And the two possibilities there are a single surgery, what we call a combined kidney and pancreas transplant. That's where both of the organs come from the same deceased donor. So it's a single surgery, one hospitalization.
Is this better than getting them separately? I'm sorry.
Well, so the other option would be to get it separately. And that's typically what we might do in somebody who has, say, a potential live kidney donor and wants to get the kidney transplant done so that they can kind of either get off of dialysis or avoid dialysis, and then subsequently get what we call a pancreas after kidney transplant. And which strategy is best is going to depend on the circumstances of the individual patient. And that's one of the things that we go over during the initial evaluation, trying to help sort out whether or not someone might be better served by getting the combined 2 organs from the same donor, or whether they're getting the kidney transplant first and subsequently getting the pancreas transplant. With the end result in both cases being that you have a functioning kidney transplant, so you don't need dialysis, and you have a functioning pancreas transplant, so that you no longer need to give yourself insulin.
So maybe let me just fill in there, because of course I had this experience, and this was a great intro, and just wanted to give my point of view there, because when I first came to Columbia, and it was Columbia, I was fortunate enough to be under your care. You know, I didn't really consider pancreas, but I knew that I was very late stage kidney disease. I wasn't really at that time aware, even though I am trained as a physician, that I really needed a kidney transplant, because I had maybe not truly accepted it. But in the evaluation process, it was clear that I needed a kidney transplant, or else I would be on dialysis within the next few months. And in my case, I was very fortunate enough to have a living donor. And because I had that and I wanted to avoid dialysis, we planned the kidney, which can be planned in the case of a living donor, which is, I think, smoother in that sense, that you can set a date and you can be prepared, and it's a little bit more comfortable. However, my general condition when I did my kidney transplant was much worse than when I 9 months later did my pancreas transplant, because of my electrolyte imbalance, my anemia, and you know, the general condition that the end-stage renal disease had placed me in. So it was an advantage for me as a patient, I believe, to do the less severe surgery. Maybe we should talk about the surgery for pancreas. And do only the kidney first, and then wait 9 months, get back, you know, in a little bit better shape, because now I had a normal kidney function, but I still had type 1 diabetes. I still had to dose insulin, which was still leading to issues for me, because I was very brittle in my diabetes. But when I got the call for the pancreas, I was in better physical shape than I had been 9 months later. So the pancreas transplant in itself, and we'll speak to Dr. McCune and Sandoval, about that I think it was a lengthy surgery. And I did have more complications from that than I had from the kidney. I could deal with it better. First of all, I had a better kidney function. I had a normal kidney function. And secondly, of course, I didn't have diabetes anymore because I now had a functioning pancreas. So that's my perspective, and it's an N of 1, and I was lucky enough to have the living donor option. So just wanted to give that as well to the picture.
So now that we know that we can have it either simultaneously or after the kidney, Dr. McCune, can you comment very briefly about getting the pancreas before the kidney fails and try to save the kidney?
Certainly, you can have a pancreas transplant alone. Generally speaking, this isn't your average diabetic, somebody who's difficult to treat, that multiple attempts have been made in different ways to control their diabetes. And as Dr. Herrenberg was suggesting, they're still brittle despite all of that. Most or all of these people have some sort of side effects of their diabetes that are permanent. So they may not be able to tell when their sugars are too low, so they're at risk to have seizures, those kind of things. And in those situations, we take a look at them. And certainly it's one of those things that they're looked at by an endocrinologist and us, and we make the decision that pancreas transplant is their best option. And then we can move forward with just pancreas transplant by itself prior to their kidney failure.
I think linked to that question, Dr. McCune, there's a patient here who says that she's 62 with type 1 diabetes for 38 years. Is she too old to get this kind of transplant?
I think the short answer is no. I think when we look at patients who get a pancreas transplant alone over 60, we really want to know we're benefiting them. So it's a selected patient over 60, somebody who's pretty healthy, can handle a big surgery really, really well. And we think they still are going to need some time without diabetes, and we're going to be able to benefit their life with giving them a pancreas.
Do you look carefully at the business of hypoglycemic unawareness on those patients?
Absolutely. That's the top indication for a pancreas transplant alone is hypoglycemic unawareness. And certainly there's talk in the field about other indications, but that's really the one we focus on.
And let me just explain what that is, just for our patients. So hypoglycemic unawareness is when you go low in blood sugar, but you can't feel it. Normally, when you go low in your blood sugar, you start sweating, cold sweat, you shake, you feel like you have a headache, you get nervous, anxiety. And those are all signs of low blood sugar, or your body's response to low blood sugar rather. And most people with diabetes recognize those signs, and we know that you have to drink juice or have something to eat. In the cases of hypoglycemic unawareness, those signs are no longer there because the body has become resistant to the hypoglycemic, and also the nervous system is disrupted. So you have so-called autonomic dysfunction. And I can tell you, I was exactly my case. I would be driving and I would not know that I was low blood sugar. And that is a very scary feeling. And on another occasion, I literally passed out in my own home because I didn't feel the low blood sugar. And in those cases, you need intervention, because if you're passed out and you cannot drink that juice or have that milk or have that piece of sugar, you need intervention. And that could be a glucagon pen, which most people with type 1 diabetes have in their night table, or and now they have them even as a nasal spray. But eventually, if it goes too far, it will mean intravenous or glucose infusion to correct the imbalances, plus other interventions, because when your blood sugar goes so low, you need more.
But the reason I asked the question is that this 60-year-old woman with type 1 diabetes happens to have a series of car accidents in the recent past. She might be benefited by a pancreas transplant sooner rather than later, before she kills herself in a car accident, which is one of the major issues in patients with this hypoglycemic unawareness. Is car accidents are one of the prime problems.
Yes, and also the kind of the prequel to that, meaning that your driver's license is removed and you become dependent on someone else driving you, which at 60 years of age, you don't want to maybe be transported by someone else. So,
Dr. Sandoval, can you continue this discussion and tell us a little bit about the operation itself? In other words, what are the major risks of this operation? Where does the pancreas go? And if it goes together with the kidney, or whether it goes after the kidney, what are the choices that you make as a surgeon?
Yeah, so as we described a little bit before, it can be done simultaneously, or it can be done subsequently, or it can be done in itself. Typically, the pancreas gets two major type of connections. Like there's the vascular aspect of the pancreas, and then the pancreas has a component called exocrine component. The pancreas not only produces insulin, but it produces some digestive enzymes. So they're all together in the same gland. So those digestive enzymes need to be drained into the small bowel of the individual. That's how the pancreas does it in situ, and that's how it does it in the transplant as well. So it gets connected to the small bowel. In the past, and you might hear that it used to be connected to the bladder, but that is a practice that's going away, and very few places still use it. So I'll focus in the bowel. So those are the two components. Usually it takes midline incision in the abdomen. It takes somewhere between 4 and 8 hours, depending on the surgeon, depending on the patient, depending on the circumstances. Combined with the kidney, it usually is the latter. It's a longer operation because there's 2 transplants happening. If not, it's the pancreas alone. Now, and you implied a little bit, Dr. Heckenberger and Dr. Hardy, about the complications that can occur, and they can be somewhat frequent. The main complication that you might hear of or read about, about 1 in 20 pancreas transplants fails immediately, close to the time of surgery. And the failure typically consists in clotting of the blood vessels and clotting of the gland itself, and needs to be removed soon after that happens. So
Sorry, Dr. Sandoval, what was the percentage that you said failed immediately?
about 5%.
5%, 1 in 20, okay.
Mm-hmm. So that needs to be discussed and understood by the patient, that there is that risk. Other complications can occur that can be also quite dramatic because it's a big operation, like it was implied before. And a lot of patients that have a pancreas transplant have a lot of comorbidities associated with diabetes, including heart disease, peripheral vascular disease, and so on. So I would say that the importance is to balance what the risks are and the benefits. Typically, patients that their heart is in reasonable condition, if their vasculature is, if the peripheral vascular disease is not severe enough and allows us to do it, typically patients do benefit, meaning the risk is compared to the benefit, the risks, the benefits outweigh.
Yep. One of the questions we have from the audience, I think, and I'm making it a little more general than the person is making it, are the complications to diabetes, right? The complications to diabetes, including kidney failure, eye disease, as well as autonomic dysfunction and hypoglycemic unawareness. When you get your new pancreas, and this I think is truly interesting, and maybe Dr. Dube, you're the best one to talk about this, being more of a nephrologist. What will happen to those complications? Can you expect that hypoglycemic unawareness will go away? And what about the retinopathy and the kidney disease?
And the vascular problems.
And the vascular problems.
Yeah, so great question. So, with diabetic, we'll start from the head and work our way down. So with diabetic eye disease or retinopathy, getting back to normal blood sugar control, which we would see after a pancreas transplant, can basically stop the progression of diabetic eye disease. If there's been any kind of laser treatment of other surgeries that's caused scarring in the eyes prior to the pancreas transplant, that type of scarring can't get reversed, but at the very least, you won't see progression of the diabetic eye disease once you've reestablished normal sugar control. Over time, after there's less data on patients with diabetic nerve disease or neuropathy, but over time after the pancreas transplant with normal sugar control, we tend to see stabilization and then sometimes actually slow improvement in symptoms of peripheral neuropathy over time. Nerve regeneration doesn't happen quickly though, so that's something that we tend to see over years rather than weeks or months.
So that would be the symptom. There would be low sensation, or you can't feel your feet, or there's increased feeling in your feet, right?
Right, that kind of.
Well, the worst part is the early one where you have some pain, actually.
Yeah, the pain and burning can slowly resolve afterwards.
The burning.
That might be due to just better kidney function if you're getting the combined kidney and pancreas transplant, because kidney disease can also cause some of the similar nerve symptoms. With diabetic kidney disease, if you get the combined kidney and pancreas transplant, you would not see diabetes developing in the kidney transplant as long as the pancreas transplant is still working. If you were to get a kidney transplant just by itself, those people who wind up subsequently getting the pancreas transplant, just getting back to that normal blood sugar control can actually prolong how long the kidney transplant is going to work inside of your body. So it can also slow down the diabetic complications in your kidney.
To me, that was one of the biggest selling points for getting a pancreas, was the prolongation of making sure that the new kidney also was going to do better. Yeah.
And then there's.
We have to point out also that the new kidney in a diabetic patient can get diabetic changes. It takes about 5 years to see them histologically, but they can actually lose the kidney in anywhere from 8 to 15 years because of diabetes.
Correct. Yeah. And so that's another benefit to getting the pancreas transplant, whether it's at the same time or if you have the living donor afterwards. And there are some data as well suggesting that with longer follow-up after your pancreas transplant, that can slow the progression of diabetic complications in the bigger vessels, things like heart attacks and strokes and blood vessel issues in your legs, what we call peripheral vascular disease.
And the hypoglycemic unawareness.
So once you have a pancreas transplant that's working and it's making insulin and it's making the other hormones that a normal pancreas makes, the hypoglycemic awareness symptoms should go away and should stay away for as long as the pancreas transplant is working. And then even in some cases, the pancreas transplant kind of will stop working, meaning that you need to go back on some amount of insulin, but it still makes some insulin and the other hormones, just not enough to keep you off insulin. And so it can still help protect you from the low sugars at that point, even if you still need some insulin to prevent the high sugars.
And you mentioned before the exocrine function of the pancreas. You're not removing the existing pancreas, the native pancreas. So doesn't that pancreas supply the exocrine function, or has that been replumbed, during the surgery?
So there's no replumbing from the old pancreas during the surgery. Most patients who get a pancreas transplant, their old pancreas, the one they were born with, continues to make normal digestive enzymes, and so they don't have issues, GI issues from that. But there is a subgroup of patients who get the pancreas transplant where the digestive enzymes weren't being made normally in their own pancreas. And for those patients, actually, they will see improvement in some of their chronic GI symptoms. For example, sometimes people have chronic diarrhea or malabsorption that can actually get better after the kidney transplant or after the pancreas transplant, simply because the new pancreas is making enough of the digestive enzymes that they couldn't make on their own.
Casey, can you comment briefly about another complication that really is terrible to the patient? That's gastroparesis, where the patient vomits and retches for no good reason, actually, except that the stomach doesn't empty properly because of the neuropathy. What happens after you do the pancreas transplant? Is there anything that will help it?
Well, I think all of the neuropathies, as we're kind of talking about, usually stabilize after the pancreas transplant. And over a long period of time, we may see some of them get better. Gastroparesis is a tricky phenomenon. I think what's fair to say is somebody who's a bad gastroparetic, meaning they're coming in and out of the hospital with nausea, vomiting, post-transplant, they may see that get a little worse at first because they've had a big abdominal surgery and things need to heal. But over the course of kind of 6 months to a year, we should see them stabilize out to where they were or improve a little bit with time. It's interesting, Dr. Hardy's talking about this. This is something we collaborate with here at Columbia with the gastroenterologist about gastroparesis and its treatment. And certainly there's a subset of patients who need additional procedures, either with GI docs or with medication or with us, to help some of those symptoms and improve their lifestyle.
When it comes back to the criteria for those who are eligible, I think Dr. Dube, you said you need to be diabetic and you need to be on insulin. And that would include some people with type 2. But some people with type 2 are on maybe long-acting insulin and not short-acting insulin. How would you include a type 2 diabetic here in the pancreas transplant program?
Well, so we don't have really different selection criteria for type 1 or type 2 diabetics. So if you are a diabetic who's on insulin, the things that we would look at would be how much insulin are you using per day? And that kind of gives us a rough estimate of how much of your insulin requirement is due to just you're not making enough insulin versus you're very insulin resistant. And if you're on very high doses of insulin, the likelihood of a pancreas transplant being able to get you off insulin goes down close to zero. Whereas if you're on fairly low doses of insulin, whether it's only long acting or a combination of short acting and long acting, or a relatively low dose on an insulin pump, most of those patients will wind up being able to come off of insulin successfully after a pancreas transplant. So we're looking at the total daily insulin requirement. The other thing we tend to look at is, and Dr. Sandoval and Dr. McCune can comment a little bit more on this, is, in terms of your weight, in terms of how it's distributed. So we know that overweight and obesity is a fairly common occurrence in this country. You can do pancreas transplant successfully in patients who are not completely thin, but as the weight goes up, you need to look at the distribution and see whether or not surgically it might be technically feasible to do the pancreas transplant or not. So those are kind of the two things that we'll look at, not just type 1 versus type 2.
Is there a correlation between the weight and the insulin requirement in those fat patients in type 2?
I think so. I think it also kind of depends on what your goals are. When we treat diabetes, be it with insulin, with weight loss surgery, or with transplant, we're really looking to improve someone's glycemic control. So we want somebody to be not a brittle diabetic. And so true, when we look at an obese patient who's a type 2 diabetic, they're making plenty of insulin. So in some situations, if we add another pancreas on, it's not necessarily going to cure their disease, may or may not give them better glycemic control, but in its setting of them having other issues going on, we need to weigh the benefit and risk of doing a big surgery on them to try to cure the disease.
But would you push them or suggest strongly that they have a bypass procedure, some kind of a gastrointestinal bypass procedure, in order to reduce their weight and probably get rid of their diabetes in type 2?
I think, yes.
The success is about 85–90% in some operations.
Yeah, absolutely. I think when we talk about type 1 versus type 2, we have to be cognizant of, even though we are using some of the same therapies, they're very, very different diseases. One, people aren't making enough insulin. The other, their body has become resistant to it for one reason or another. And so whether adding more insulin or decreasing weight, whatever the option is to try to cure their diabetes, we have to look at the individual patient every time.
When we look at the success rate of pancreas transplants, what we talked about kidney in the past and the difference between living donor and diseased. Here we don't have the option of a living donor pancreas. So what is the national success rate of a pancreas transplant? How long does it survive on average?
Well, when we look at success rates of transplants in general, we look at living donor kidney transplant as the gold standard, as the safest surgery and the most successful one, right? And what we generally see is a success rate of about 98% as far as patient survival and graft survival. For a pancreas transplant, we look at a patient survival of 96%. So this is something that should be a very safe procedure. It should be something that's generally successful. As Rodrigo alluded to, there's about a 5% chance that you may have an issue that takes your pancreas away quickly, because it is a big surgery and it does have risk and those kind of things, and it's not necessarily diabetes, like being treated with insulin. But it should be overall if patients are selected appropriately and are a good surgical candidate, it should be a very safe and successful surgery. And generally speaking, we see outcomes, and I tell people to ballpark 10 years. The different institutions have different success rates, but they should expect that their pancreas lasts about 10 years if they have a good surgery.
And what makes it, what kind of factors will impact the loss of the pancreas? Is it autoimmunity coming back? Is it rejection? What normally is it fibrosis? What causes the pancreas to be lost after 10 years on average?
I think it, like transplant, like anything else, is kind of the straw that broke the camel's back. So bad events are bad events, and they chip away at your success rate as you kind of move forward. So I think absolutely to everything you're implying. So rejection may chip away at it some. Not being able to take your medications because you lost your insulin or your insurance is going to chip away at it some. Weight gain is going to chip away at it. Even if you're type 1, you may transition into being a type 2. So there's lots of factors that go into graft loss over the period of time.
Okay.
And perhaps you can comment on this, Rodrigo, is in terms of the vascular problems that these patients have or cardiac disease that they may have before they come to you for transplant. And these are diabetic patients who may have been diabetic for 20, 25 years. And the problem with that is they're also hypertensive. They have some cardiac disease. They may have had a bypass. They may have vascular disease in their legs. How do you approach that kind of a patient? When do you call it too high a risk to put a pancreas in? Or are all of these patients okay if everything is corrected?
So I think that you allude to a very important issue that kind of like may help better explain how we approach the procedure in terms of who we offer it to, who we don't offer it to. So although we do not distinguish in the program type 1s versus type 2s, there's kind of like a very clear difference in presentation, right? So the juvenile diabetic versus the adult onset. And after 25 years of disease, a lot of the patients of the diabetics are going to have, like you said, coronary disease, peripheral vascular disease, and a lot of the other symptoms that and signs that were mentioned. So we do this as a multidisciplinary group. So we will have an evaluation with a cardiologist, with surgeons, with nephrologists, and so on. And we will ensure that the patient not only will tolerate the procedure, but will benefit from the procedure. So coronary disease, for example, it might not suffice to be able to survive the procedure, but we want to make sure that the patient will benefit, will have the longevity that will make him benefit from such a big operation and so on.
So you put them through all the cardiac tests?
Yes, so they will go through a cardiac test, and a cardiologist will evaluate them and make sure that they're fit to undergo the operation. The peripheral vascular disease, we will assess it ourselves as surgeons, and typically we can deal with the majority of peripheral vascular disease that patients might present, other than when they're very advanced, when they have terminal type disease of peripheral vascular, where the blood vessels are extremely diseased, and so then those are the vessels that we need to plug in the organ to. So if they are not healthy enough to be able to do it, that will rule them out. That is at least for what we see, is not a common cause for rule out. But talking about type 1s and type 2s, when I see a patient, a type 1 diabetic, the pancreas transplants will, like Dr. Dube referred to, will manage not only the diabetes, but it will help the complete syndrome that comes with it. So we'll slow the progression of coronary disease, slow the progression of retinopathy, will slow the progression of kidney disease, will slow the progression of the diabetes and its other consequences. The type 2 diabetic is a different circumstance, especially if it's linked to obesity. So in those patients, we might be able to reverse the diabetes or improve the diabetes, but we're not fixing what we call the metabolic syndrome that the obese patient has. And then Dr. Hardy alluded to this, the the gastric bypass might be a better option in terms of fixing the whole syndromic effect of the metabolic disease that a patient has linked to obesity. So it will fix the lose of weight, might fix it on itself, the diabetes, the hypertension, the sleep apnea, and the hyperlipidemia, and so on and so forth. So I think that might explain a little better how we approach patients like that.
I think that's really well said. One thing that we haven't discussed is the, when you speak to a person with type 1, they normally say there are additional 200 decisions to be made every day because life is governed by blood sugar values, and that takes up a lot of space in your mind, managing life and also managing type 1. And when you remove those decisions and you get, pancreas that works, that also really improves the mental state and the psychology of the patient with type 1, and they can better probably handle, everything else in life, meaning also the kidney transplant that they still need to manage, and the medication, which we haven't discussed, but the medication for a pancreas transplant, and you can comment on that, but it's the same as for the kidney transplant patient. So, I think that's really important. The difference here between type 1 and type 2 also, I think, is significant because type 1 is more volatile and needing that minute-to-minute management of blood sugar and insulin is taking a toll on that person's life. I mean, I speak from personal experience. The moment I woke up from the pancreas transplant, it was, a relief. Not even though I was in the hospital, it was just a different life to not have to think about type 1 diabetes anymore.
Absolutely. I'm sorry to interrupt, but the other point is that when we talk about pancreas after kidney, like in your experience, so for individuals, it's important to know that some of the medications we use to manage the kidney transplant or the transplants in general can be diabetogenic, meaning they can cause new onset diabetes in certain patients, or they can aggravate the diabetes that a patient already has. So that for type 1 diabetics is very important because a lot of them will not only pursue the pancreas transplant, but they want it soon after the kidney because of that same reason, the diabetes getting much worse.
And I will make a plug there that when you get your pancreas, I mean, those of you listening and waiting for it, doesn't mean that you're suddenly going to start eating ice cream and cookies, because at least in my case, I became almost more diligent after I got my pancreas in my diet, just because I didn't want to get myself type 2 diabetes after getting a new pancreas. I want to keep it pristine. So I think it's very important with the drugs that we are taking to keep a very healthy diet.
Casey, perhaps you can comment briefly about what kind of a pancreas will you accept? I know that these are real issues in terms of whether it's a good pancreas, bad pancreas, and that really does dictate a little bit on how well it works afterwards. And those choices have to be made before the transplant is put in, obviously. And I know that you and Dr. Sandoval make these choices beforehand. So could you comment briefly on what is really acceptable or desirable in those terms? And why don't we do more of them? Because there are a lot of pancreas that are not being used.
Pancreas selection is really based off of the donor. And it's interesting because you only can really use young, healthy donors. So these tend to be people who are less than 40 years of age, tend to be fairly lean, and depending on their life leading up to their ultimate death to become a deceased donor determines how healthy the pancreas will be for it. The next thing we do is we take a look at it. So when they're taking the pancreas out, they'll send us how healthy it looks over a picture. And then we'll do our last quality check when it comes to our operating room, and we take a look at it and we make sure it's high quality there as well. But the only pancreata that we're really able to use are high quality. We have tried in the past to be more aggressive And this is part of the reasons there's not more pancreas transplants. And those donors that really aren't as high quality, those pancreata just don't work as we think they should. So that's when we hear more about those complications of them getting a blood clot in them and having to come out. That's when they don't last quite as long. They're just not effective if it's not a high quality donor.
So if someone is 60 and trim, they're not a good donor anymore?
No, we know that two things majorly affect it. One is age. So the younger the donor, the better quality the pancreas graft is. And then how heavy they are, their BMI. So the heavier the donor, the lower quality the donor is. So kind of where they intersect. If you have a young skinny donor, obviously, but 60 is a little excessive for even a healthy person to take a pancreas from.
And the follow-up in terms of the patient after they get the pancreas, how do you follow them, Dr. Dube? How often do you see them, and how do you adjust their medications? Are you a little bit more conservative, lowering their medications than you are with kidneys, or is it pretty much equal?
So for the combined kidney and pancreas transplant patients who get them at the same time, the follow-up is essentially the same as if you just get the kidney transplant alone. The medications are the same, our kind of goal drug doses for the anti-rejection medications are the same. You're going to be seen very frequently in our transplant center in the first few months, and we kind of gradually space out how frequently you're coming in. Although we get labs checked over the long term. For the pancreas after kidney transplant, so you have the kidney transplant like Dr. Henberger did, and then you come 6 months, a year, or whenever, and you get your pancreas transplant. The risk of rejection in that setting may be a little bit higher, and so we tend to run the drug levels maybe at the higher end of the range, as opposed to kind of in the middle or lower end of the range. But generally speaking, at our center, the follow-up is going to be the same for the transplant, whether you get a kidney by itself or whether you get the pancreas transplant. Other centers may choose to follow their patients somewhat differently, but I think most centers tend to be a little bit more conservative in terms of how frequently they see their pancreas transplant recipients over the long term, simply because it's a less commonly performed procedure, and a lot of local nephrologists who may have experience seeing kidney transplant patients may not have the same comfort level seeing patients after a pancreas transplant.
When it comes to detecting rejection in the kidney, you can do a biopsy pretty easily. In the pancreas, it's not as easy. So how do you monitor that?
Dr. Sandoval, why don't you give it a try?
There's several ways to monitor. We talked a little bit about the exocrine portion of the gland, so we can monitor some enzymes that the pancreas produce, and that they can be measured in blood. So those
aren't those also coming from the native pancreas?
They are, but typically they won't be elevated from the native pancreas, other than if the patient has a problem with the native pancreas. So a patient that is asymptomatic, because rejection, as people know, in its usual forms, tend to be asymptomatic until it's late. So the enzymes can be a good way of monitoring, because they will be elevated if the pancreas is inflamed, which rejection will cause, among other things that could cause pancreas. Also, we can have imaging that could give us an idea of what the pancreas looked like if we suspect anything is going on. So
what happens? It gets swollen?
It gets inflamed and swollen. Yes. And then we will follow the blood sugars, but that is, an anomaly in the blood sugars, typically in pancreas transplant, indicates a late presentation of a problem. So the majority of the tissue, the working organ of the pancreas must be malfunctioning for the blood sugar to elevate.
So if the amylase or those enzymes go up a little bit, what do you do, Dr. McCune or Dr. Dube? When do you biopsy them? When do you lose the patient and stick a needle in?
We kind of want to see consistent elevation of their amylase or lipase.
How many days?
Well, usually this is as an outpatient. So you're kind of seeing people maybe twice a week and getting lab values there. And so I think at about a week and a half of consistent, so like maybe 3 levels, it's continuing to go up or staying pretty high. Then you start going down the algorithm that eventually leads to biopsy. Most people will check a C-peptide first, that byproduct of insulin creation in the body, to make sure that the pancreas is still making enough of it. Sometimes we'll get a CAT scan to make sure there's nothing else going on in the abdomen that could potentially elevate those enzymes. And then it's usually followed by a biopsy to see if there's any sort of rejection going on.
So can the patients get their own test at home and for amylase or lipase?
Generally speaking, no, but I'm sure some people can. No, but you usually have to go to a lab and have your bloods checked.
But would you recommend it if the patient? Would you recommend that the patient in this, particularly if they have a little discomfort over the area or something like that, that they run to Quest Laboratories and get an amylase?
I think if they're having discomfort over their pancreas allograft site, they should probably call us and see what we
And come in.
Yeah, potentially they call the on-call coordinator. We end up talking to them and then we figure out what we think is going on.
So that brings me to one last question. If I don't live in New York, but I live in, let's say about an hour and a half, 2 hours away from here in Albany, I guess that's a little further. Can I come here and get a pancreas transplant? Will that work, Dr. Dube?
Sure, absolutely. We don't have any geographic restrictions on where we'll see patients from. So we've had, patients coming here to be evaluated at Columbia who live, 2 blocks from the hospital, and we have patients coming here who live 2,000 miles away.
But do they have to stick around for a while, for 2 months, 3 months?
Well, obviously, one prerequisite of getting a pancreas transplant is that you'd be able to get to the hospital in time for us to do the pancreas transplant. So if you have a way to get to the hospital in a reasonably short period of time, and if you're, say, live in Chicago, there's a lot of flights from Chicago to New York.
But everything went very well.
After the transplant, typically we'd like people to stick around for 2 to 3 months, if possible, because that's when the majority of technical complications are going to be seen. And so that's when we're seeing patients once a week, even twice a week still. But long term, we'll have patients who, whether it's for kidney or kidney and pancreas, they live far enough away that they'll just send us copies of their labs, and maybe they come to see us once a year. With telehealth visits now, it's actually gotten easier. Some patients we can just do a quick Zoom visit with, check in with them, go over their blood sugars, blood pressures, etc.
Yep. We've been referring to the native pancreas. There's a patient who's asked a question here if the original pancreas is left. Yes, that's what we have referred to as the native pancreas or the old pancreas. So yes, you, not me, you leave it there. You don't remove the original pancreas. And that's also where we've talked about the exocrine function, meaning the digestive function that has often accommodated by the old pancreas. So that's just an answer to the question. I think we've come to a point where we really, this is a really interesting topic. And, one thing that after listening to you and of course experiencing myself is, why isn't this done more? Why aren't more people with diabetes offered a pancreas transplant? And I think, we have not really talked about the lack of supply, and there is a lack of supply, but we have talked about the long surgery and some of the complications. And I think the other thing to emphasize is the immune suppressive therapy that people need to be on post-transplant. So you don't really do this in children unless they have a kidney transplant as well. You don't do it in people who have long lives ahead of them unless they also have other big issues, or the hypoglycemic unawareness, as we've discussed. However, I think in a future seminar, we are going to talk about opportunities such as, which is the 2.0 of the pancreas transplant, not islet transplant, but stem cells. And how if we could get to stem cells that have an abundance of supply, But we still need to deal with immune suppression, because right now stem cells need immune suppression as well. So there's a combination of building up a very large and low cost supply of stem cells that can become beta cells or insulin producing cells, glucose sensing cells, but also some sort of protection, either mechanical or immune modulatory. Anything?
Or get piggy islets
Yeah.
from the pig.
That's how it all started, right? Well, it was dog, I guess. Started with dogs.
That's how insulin
Yeah.
was used. The insulin that we used did come from pigs.
Yep. No, when I started with diabetes, I mean,
Lily made a fortune on that.
yeah, I had pig insulin.
Yeah.
And I'm still here.
So just before we leave, suppose you do a pancreas transplant. I get a pancreas transplant, but unfortunately, after 15 years, it really gets all fibrosed and doesn't work anymore. Can I get another one? Will you give me another one, Casey?
Absolutely.
You like me enough to do it?
Absolutely. And once you're plugged into a transplant center, we're monitoring how well you're doing and making sure that where you are in your graft function. So as it starts to fail, if you're interested in another one, we sit down, we talk about it, and we talk about the risks and see if it's appropriate for you.
And Dr. Dube, do the drugs that we use, do they actually cause some fibrosis in the pancreas like they do in a kidney?
So some of the drugs that we use can elevate your blood sugars, but that's not a major contributor to long-term reasons why the pancreas transplant fails. Which most commonly is going to be due to kind of a slower chronic rejection.
So it's not scarring.
It's not scarring in the same way that occasionally that can happen in the kidneys.
Well, I think that we're slowly coming to the end of this session. And does the audience have any other questions?
I think we've answered the questions, and we've also answered the pre-session questions. So I think we're in good shape.
So thank you very much to the panelists. I think it was an exciting and a very informative session.
Yeah.
And I'm grateful for your participation and for keeping close to the topic and answering the questions in a perfect manner.
It was great.
So
yep.
Thank you very much. And I want to thank Veloxis for supporting this effort. And I want to just tell our audience that we're going to go again on July 20th. We're going to have another session that will also focus on the pancreas. And we will try to answer new questions. So the audience should prepare them carefully. And we will have some of the same panelists, but we also will have some new panelists that will put a little different perspective, perhaps, on the whole idea of pancreas transplant.
And to all the other organ recipients out there who do not have kidneys and pancreata, please, we are going to do livers and hearts and intestines, and lungs eventually. We'll get there. I know there's a huge demand for it. So we really look forward to bringing that to you eventually.
Well, thank you very much.
Thank you.
Thank
you.
Have a
Good night.
good evening.
Good night.
Good night.
Thank you.